Hello, and welcome to this CME activity. I'm Nizar Tanir from MD Anderson Cancer Center, and I'm pleased to be joined by Dr. Robert Motzer from Memorial Sloan Kettering, and Dr. Brian Rini from Vanderbilt University Medical Center, and Dr. David McDermott from Beth Israel Deaconess Medical Center and Dana-Farber Harvard Cancer Center. In this activity, we're going to discuss clinical evidence from recent trials in RCC that led to the approval of 3 first-line regimens. In this exchange, we will examine the risk stratification and patient selection, treatment sequencing, management of immune-related adverse events, and future directions for RCC therapy. So let's start with reviewing the 3 clinical trials that led to the approval of these 3 regimens. And I'd like to start asking Bob, can you review for us the design and the clinical results of Javelin Renal 101? You led that trial.
Yeah, so the Javelin Renal 101 study was a randomized phase 3 trial that compared avelumab plus axitinib versus sunitinib in first-line treatment for RCC. It was a global phase 3 trial. The sponsor was Pfizer. And the primary endpoint of the trial was progression-free survival by independent review in patients who are PD-1 positive or PD-L1 positive. A co-primary endpoint was overall survival in the same group, and key secondary endpoints were progression-free survival in all comers as well as overall survival in all comers. And so it completed enrollment, and at the interim analysis, the primary endpoint was reached, which showed improvement in progression-free survival in the PD-L1 positive group. There was also improvement in progression-free survival in all comers, but the overall survival endpoint was not reached. The overall survival results were immature and continue to be analyzed with subsequent follow-up. In that trial, the safety profile for axitinib and avelumab was quite favorable. There was a very few proportion of patients who had select immune-related adverse events, although we did see side effects associated with chronic tyrosine kinase inhibitor therapy, such as diarrhea and skin toxicity. So it was approved. It met a primary endpoint and is available for use in the United States, Europe, and many other countries.
Brian, the other regimen that obviously combined axitinib with another immune checkpoint inhibitor was pembrolizumab, the KEYNOTE-426. You led that trial. Can you tell us a little bit about also the same, as Bob mentioned, about Javelin Renal 101?
Sure.
The design and the top-line results?
Sure. So KEYNOTE-426 was really very similar to Javelin 101, conducted in a similar period of time, an axitinib-based immune combination, in this case pembrolizumab, not avelumab, sunitinib control, large global randomized trial. Co-primary endpoints were PFS and OS in an ITT population, so not in a PD-L1 positive population as with Javelin. And this trial met both of those endpoints. Overall survival was significant. Hazard ratio was 0.53. PFS was significant. Medians were about 15 and 11 months. Hazard ratio 0.69. And then also a response rate advantage, with the response rate in the combination being nearly 60%. So it was really sort of quite impressive across endpoints and across sort of patient subgroups. In terms of safety, again, very similar to what Bob mentioned for the other combination. Diarrhea and fatigue and some of the TKI toxicities, and an expected amount of IRAEs, but I would say generally well tolerated.
Thank you. David, you were a key investigator in the Checkmate 214, which is the first IO-based first-line therapy for RCC. Can you summarize for us the design and the results?
So there's some similarities with Checkmate 214 and the other trials we've described. A large study done all over the world, over 1,000 patients. Some important differences, though. PD-1 based therapy in the front line, but this time the combination arm is not VEGF blockade, it's CTLA-4 blockade. So it's PD-1 plus CTLA-4 with nivolumab and ipilimumab. Clear improvements with most of the primary endpoints in that combination, but compared to sunitinib, which is the old standard of care. But another important difference is that the main focus of this was in the intermediate and poor risk patients according to the IMDC criteria. So even though all patients were enrolled in all categories, the main look was looking at, what are the impacts in that group of patients. So one of the exciting things about the field of PD-1 blockade is it seems to work better in patients with more aggressive forms in kidney cancer. So we saw clear benefits in both intermediate and poor risk, and as we've gone further, benefits also in the entire group of patients, the intent to treat population. The good risk population is not where the combination is approved. We see interesting activity there, but sunitinib also performed very well in that study, particularly in that subgroup as well. So that's an approach that people have continued to use in good risk patients.
So just to follow up on this point, David, and obviously, this is the same question for Brian and Bob. You speak about the IMDC risk. We all spoke about the IMDC risk and favorable, intermediate, poor risk. Can you compare and contrast the stratification among those three trials? Like Checkmate 214. Did they use that? One of the stratification was the IMDC risk. Just tell us a little bit about, obviously, the IMDC International Metastatic RCC Data Consortium was developed in the era of VEGF therapy, basically.
Correct.
And now we're applying that same stratification for immune-based trials. How was the Checkmate 214 and the Javelin Renal 101 and the Keynote 426, how were they different in terms of stratification, and how did they select patients for these trials?
So the main difference, as I mentioned, is for the Checkmate 214, the main focus was on intermediate and poor risk patients as for the primary endpoints of the study, whereas for the axitinib-based combinations, they're looking at the entire population, and they saw clear benefits across all subgroups. To your point about the clinical criteria, the IMDC criteria, those were clearly established in the era of VEGF blockade. Now we're in this new area of PD-1 blockade, so it's not entirely clear how well those clinical endpoints will predict for prognosis in that era. We may need new ways of stratifying patients and predicting their outcomes with these new therapies.
Brian, you would like to add anything about, do you think, Bob, I think the Javelin Renal 101 was the only one among the three that focused on PD-L1. And do you think this was done, the trial was designed from the outset with the PD-L1, or was changed later on to really focus as the primary endpoint, the outcome or efficacy endpoints in the PD-L1 population?
So for the Javelin Renal 101, when it was originally designed, it was all comers.
Right.
It wasn't, the primary endpoint was not specifically in the PD-L1
So
positive
the Keynote 426, it wasn't all comers, right?
But there was a small single-arm trial that was performed with a combination in RCC, and an early look suggested there was a higher response rate in the PD-L1 positive. So the trial design, the primary endpoints were changed early on in the conduct of the study.
So that's the only, among those three trials, it is the only trial that focused on PD-L1 as one of the stratification factors. Keynote just took all comers.
It was just all comers, yeah.
And the endpoints were PFS and OS, and all risk groups and all comers, regardless of PD-L1 expression.
Right.
Checkmate, as David mentioned, was focused on the intermediate risk, poor risk by IMDC definition. And the other interesting thing about the design of Javelin was that in addition to the PD-L1, they looked at ECOG performance score as a risk stratification, right? Zero rather than the IMDC risk, whereas the other two trials, Keynote and Checkmate 214, were they looked at IMDC rather than it. Do you think that difference was the reason the results were a little different? What do you attribute the results, for example, of OS that was met with Checkmate 214 for the ITT as well as the intermediate risk poor risk, and of course for the all-comers for the Keynote 46. Yet you mentioned that OS did not, was the endpoint for OS was not met. Maybe it will in future follow-ups, but at the primary analysis 12 months after, with a median follow-up for Javelin it wasn't met. So do you think, how you attribute that lack of OS for Javelin Renal 101?
Well, I think there's three possibilities. One is that it could have been some aspect of the study performance, where the patients were treated in what part of the world, access to subsequent therapies, were people who progressed on sunitinib salvaged by the use of IO therapy and subsequent treatments, since most of the patients in that trial came from the United States. Another is the timing of the analysis. I mean, right now the data is immature. It may become, with maturity, may show a survival benefit. Or the third that's been raised is the fact that avelumab is a PD-L1 inhibitor, and it's also possible that PD-L1 inhibitors don't have the same level of activity as PD-1 inhibitors, and aren't enough really to kind of boost things to the degree where we actually see a survival benefit. So I think it's one of those are the three possibilities for the difference in outcome that's been reported with that trial compared to some of the others.
Brian or David, would you like to add?
I mean, I think I tend to believe
your interpretation of.
Mine would be that it's number 3, that there's clearly a difference between PD-1 inhibition and PD-L1 inhibition. We also have another trial we didn't mention, Emotion 151, which had a atezolizumab PD-L1 inhibitor plus bevacizumab, so obviously there's a different VEGF component there. But the 2 PD-L1 trials aren't positive for survival, and the 2 PD-1 trials, Ipi-Nivo and Axi-Pembro, are. So we have, those are 4 large phase 3 trials. To me, that's a pretty clear signal. Now there are some other trials coming. I don't know if we'll talk about those, but that might add to that data set as well.
I think in addition, when you look at the single agent activity, at least in kidney cancer, of PD-L1 versus PD-1, so pembrolizumab alone in untreated patients gets you a response rate around 36% in a medium-sized phase 2 trial of 110 patients, with both atezolizumab and avelumab getting you less as a single agent in similarly sized trials. Why that might be is unclear, but it may explain the somewhat, at least at this point, disappointing OS outcome of the avelumab trial.
So, Hidoke, come back this IMD's risk. I mean, this is how we are selecting our patients, right? I mean, in the clinic, Brian, at Vanderbilt, you see a patient with newly diagnosed RCC, clear cell. Are you using IMDC to select your patients?
I'm not really, so I tend to use Axi-Pembro up front, and because it's active across risk groups, I'm not there calculating a score for that reason, for therapy selection. You might do it for patient counseling or just, so you have an idea of where this patient falls on the prognostic spectrum. But I don't personally use it, and this is sort of an area of debate, which is, I guess, why we're talking about it. And these were developed in the VEGF-targeted era, so they clearly reflect VEGF sensitivity, which is why sunitinib did wonderful in 214 in favorable risk, because these are VEGF-sensitive patients. So even if they're not perfect, they clearly reflect VEGF sensitivity across that spectrum. But to answer your question, no, I don't use it for therapy selection.
So let me follow up on this. A patient that you think, I mean, you look at their, the 6 criteria you mentioned, the 2 clinical performance stats is good, patient asymptomatic or minimally symptomatic, had nephrectomy years ago, now has metastasis, all the labs that you mentioned, corrected calcium, hemoglobin, platelet count, neutrophil count, all normal, so clearly the patient has favorable risk. You give them Pembro Axi.
Yes.
And if that patient had slight anemia, you still give them Pembro Axi. And if they had primary in place, they present to you with primary tumor in the kidney in situ, and they have metastatic disease, and their calcium is, corrected calcium is higher than upper limit of normal. They, what we said, that patient had 3 risk criteria, 3 IMDC risk scores. You still treat them with Pembro Axi?
Yeah, I'm not using it to differentiate. So I'm interested what these guys do, but I'm not using it. So we might measure it. We measure those things, right? Those are common to measure, but.
If the patient asked you, Dr. Rini, what's my prognosis? What do you think I'm gonna, how long, do I have a chance of cure? What's the likelihood of me responding to therapy? I mean, so basically that's when you basically look at the IMDC risk scores, and then you say, okay, well,
yeah, certainly if
you have favorable risk, you're gonna live many years.
Yeah, patients certainly ask, doc, how long am I gonna live? And so, while I don't know, obviously for an individual patient, I can give them numbers from a trial.
Sure.
Here is the median survival, though we don't have those numbers yet for these trials. Here's how people with your prognostic group do.
Sure.
So I think it is helpful for a patient's mindset of where am I along this spectrum. The cure question's a whole different topic. I think patients are being cured with metastatic disease now. It's hard to quote a number because we don't know yet. Cure requires a long follow-up, which we have decent follow-up for 214, but the VEGF-IO trials, we really only have a year of follow-up, so they're fairly immature data sets.
Sure. Bob, question to you. You led Javelin 101, the TKI, axitinib plus avelumab, the PD-L1 antibody, and Checkmate 214 with nivo-ipi versus sunitinib. Same question to you as to Brian. You have a patient at Memorial, sitting in the clinic, and you're going to see that patient, and they have clear cell RCC. Do you look at their prognostic scores? And how you then select the therapy for that patient based on, do you use, or say, favorable, I'm going to give you this. You have intermediate or poor, I'm going to give you that. What would you?
So the distinction for me is the intermediate poor versus favorable. Okay. And so for the intermediate and poor, I think there's overwhelming evidence for both ipi-nivo and axi-pembro in that population with response, progression-free survival, overall survival. So in that subset of people with intermediate or poor risk, to me, the discussion with the patient is between axi-pembro and ipi-nivo, with both of those being very good options. For patients who have favorable risk, I also think single-agent TKI with pazopanib is an option as well. So the discussion in the favorable risk patients is really axi-pembro, pazopanib, or ipi-nivo. And I think that although there may be less evidence of ipi-nivo activity or in that favorable risk group, in my own mind, it's actually the preferable regimen because of the safety profile and the long-term follow-up. So it's really more of a discussion in the favorable risk patients in terms of these different options, and there may be more weight for one based on data early on, but in the long term, I prefer ipi-nivo in that group as well.
Let me follow up on this question of some thought leaders would think that because pembro-axi, for example, or avelumab-axi had a higher objective response rate in the 50s, and nivo-ipi had a lower objective response rate than the two IO TKIs, that if you really wanted to down stage or down reduce the bulk, medically speaking. So patient has high tumor burden, they have intermediate risk or poor risk, that it is best to give them a TKI plus a PD-1 antibody or PD-L1 antibody to try to avoid having that patient not respond to therapy first line and then not making it to second line. Is that a concern for your patients, or for you? Do you really feel like this is important to get some down debulking of that disease and give them a TKI plus, or you really go with the nivo-ipi if that patient has intermediate risk or risk?
Well, I think the response rate in that population, intermediate or poor, really is about the same between the two. And also there's cross-trial comparisons. So I don't think there's necessarily a difference in response. But one of the differences is for the ipi-nivo, the toxicity is kind of all up front when they're getting the ipi. That can include hospitalizations for colitis or stopping therapy. And with the axi-pembro, I think the toxicity concern is more chronic toxicities associated with the TKI. So, there has been rare circumstances where I've used that logic and I've preferred axi-pembro to patients right up front if it looked to me like they were going to develop a life-threatening consequence of their kidney cancer, and I didn't want to chance either stopping therapy or having to deal with steroids to treat select immune-related adverse events. And so one patient comes to mind was a patient who had had a nephrectomy, and he relapsed with big-time peritoneal seeding of his tumor and had massive ascites. And so in that patient, I did offer them axi-pembro as the as the preference because of pretty much the reasons you mentioned, where I wanted to, I felt more comfortable in getting a response very quickly early on. Not so much concerned in that patient about long-term chronic toxicity.
So David, obviously, I mean, it's an important consideration, but we really do not know, we cannot predict who are the patients who are going to get into trouble with our therapies, to really have that concern that they end up with an immune-related adverse event that will require hospitalization, as Bob mentioned, and corticosteroids, etc. So really, how do we, I mean, it's just reading, looking at a crystal ball, or I mean, just your visceral intuition. I think this patient is going to get into trouble with, say, nivo-ipi, and I'm going to go give them pembrolizumab or avelumab.
Well,
Again, we're focusing on the intermediate risk or risk.
Right. I don't think there's evidence that certain populations are more likely to get toxicity. I mean, obviously, patients with a history of autoimmune disease are more likely to get the toxicity, but older patients seem to do similarly well when it comes to the likelihood of side effects, for example. I think the question, though, becomes, when you're looking at a patient, is if this patient were to get in trouble, do they have other comorbidities that'll create problems? So obviously, diarrhea and colitis are an issue, but if you're an 80-year-old person with a history of coronary disease, it could be a potentially dangerous combination of problems. So sometimes that comes into play. But if the patient is generally well medically, I'm typically giving PD-1, CTLA-4 to almost all patients for the reasons that Bob mentioned. Good activity, good long-term follow-up. We're now out to 42 months. You're presenting data at this meeting about that. Also, quality of life is something that if you don't run into one of those serious side effects in the first few months, your quality of life is certainly improved compared to VEGF, and patients, enjoy that benefit. So if you get beyond that first 3 months or so, it's probably much easier to be on PD-1 alone than PD-1 plus VEGF. So those are some of the reasons why I typically go with ipi-nivo for those patients.
So for you, to just summarize what you just said,
Yes.
off protocol, at BI, you would, favorable risk, if the patient is young and healthy, you would give nivo-ipi.
Correct.
If they're intermediate risk or poor risk, young and healthy, you're not concerned about potential immune-related adverse events with the combination, then you also give them.
Correct. They don't have to be young, but
young is like
they can be any age. Or if they have significant, right.
Chronologically young,
Yes.
physiologically young.
Correct.
Not age.
Right. There are very few people who cannot get PD-1 based therapy. There are some, but
Sure.
it's the majority can get it and the majority can tolerate it. But you need to be paying attention to those patients, though. I think that's the key.
Sure.
If you get any side effects on someone who's getting nivo-ipi, in many cases, I will not give another dose of ipi until I understand, is this mild side effect going to improve or is it going to get worse? Because until you know the answer to that question, if you give more ipi in that situation, almost whatever they have is going to get worse. So that's
Sure.
outside of a clinical trial, you have the flexibility of holding doses and using your judgment
Sure.
to sort of make your way through it.
Do you believe, I mean, you mentioned Keynote 426.
Yep.
In the 110 patients with clear cell RCC with good data with pembro, do you find a patient that it would be appropriate to treat them with a monotherapy PD-1 antibody like pembrolizumab, or
I don't think it's
off protocol?
Yes, I don't think it's inappropriate. That data is good, but you probably are losing something when you're not giving the second drug. So obviously, when you add axitinib to pembro, the response rate is higher, the complete response rate is higher. We have randomized data. Same thing with PD-1 and CTLA-4. When you add CTLA-4, the response rate is slightly higher. CR rate is certainly higher, and that probably contributes to some of those tail of the curve endpoints that we get excited about. So it's not inappropriate to give single agent PD-1, but you have to be honest about you're probably losing a little bit in some patients.
So just a question to all three of you. I mean, Bob mentioned that in some patients with favorable risk, he chooses still a TKI. You mentioned pazopanib as first-line therapy for a few select patients that you think just a TKI alone is appropriate. Brian, you conducted a prospective phase 2 trial in patients with favorable risk where you deferred systemic therapy.
So actually, most of those patients were intermediate and poor risk. So that wasn't in our observation study. 60%, I think, were intermediate risk. So I think there's this assumption that all favorable is indolent and all intermediate poor isn't indolent, and that's, at least by IMDC criteria, that's not the case. Favorable is VEGF responsive, and poor is much less VEGF responsive. But in terms of inherent growth rate, I think it spreads across categories. I don't give TKI monotherapy unless there's an absolute contraindication. So if you look at Keynote 426, and these data were presented at KCA last November, and you just look at the favorable risk, the question is, do favorable risk patients need an IO agent? Like, what are you getting for that, aside from toxicity, obviously? You get about a 20% bump in response rate. You get about a doubling of the CR rate. You get an extra 6 months of PFS, right? Realizing those are early endpoints and may or may not matter in that population, but they're not small, right? I mean, so there's significant benefit, to doing so as measured by those endpoints. Are there going to be long-term benefits in survival? We don't know. There is no long-term for these data sets.
Sure. So just to follow up on this. So, again, you published the results of the prospective phase 2 trial of active surveillance delayed therapy for these patients with select few patients that you felt that you could delay, and to really see how long it'll take before they actually have to start another agent. And so now if you see a patient, do you have any patient that you would defer systemic therapy, regardless of their prognostic risk category?
Yeah, so the typical patients, had a nephrectomy 8 years ago, and they had scans, and maybe 2 years ago they had small lung nodules, and then a year ago those got a little bigger, and then they come to see me, and now they're 6 millimeters, and they were 5, and then 4. So you have this natural history that you see play out of this patient having very slow growing disease. If patients are younger and healthier, I'm probably still going to lean towards starting therapy earlier, maybe not that exact moment, but earlier. As patients get older and or with comorbidities, I'm going to lean more towards initial observation. So it is very much a feel sort of thing. If somebody just walks in the door, no prior history, and has a renal mass and lung nodules, you don't know their time course. So the more data you have in retrospect, so to speak, the more you know their natural history. And then based on their comorbidities, you can judge, is metastatic kidney cancer going to be a problem for this patient? And that's kind of the equation that I use to decide on therapy. And patient preference. Most patients would prefer not to start treatment. I also think it's a little bit different in the IO era where we now have potentially curative therapy. So I think, when we were just going to TKIs, which weren't curing people and had toxicity, I think I was more reluctant to start therapy. Now with IO-based regimens, I think I probably tend to start earlier. But I still have many, many patients that I watch.
So really, unless the patient has contraindication, relative contraindication or absolute contraindication to receiving immune checkpoint inhibitor, you'll give everybody a combination of a TKI and PD-1, in this case, pembrolizumab, you mentioned, rather than just monotherapy with a TKI.
Correct.
I will say that I agree with, giving them combinations rather than single agent TKI. Except for that patient where the patient has metastatic disease to an endocrine organ where we know the biology is indolent. Let's say they have metastatic disease to the pancreas or thyroid. And of course, if they have an opportunity to be rendered without evidence of disease with metastasectomy, sure. Of course, we all do that and spare the patient toxicity of any therapy, and they can do well for many years if they just had that metastatectomy. But if they don't have a resectable disease and they have this indolent biology with metastasis to the pancreas, for example, I do, and especially if they're on the elderly side, I choose a TKI alone because I know that they're going to live many, many years and probably they're going to die of comorbidity, something else, rather than their cancer. I mean, obviously, as you mentioned, it's all feeling your way around, which is going to basically ultimately be the cause of death. It's like the prostate cancer paradigm or CLL, paradigm where patients are going to live with their disease and die of something else, old age, and some.
I think a question that the field has not done a good job of answering is sort of what David alluded to. What's the role of IO monotherapy? I'm certain that there's a subpopulation that can get it and do well for a long time. I know that. I don't know how big that population is, but I know it exists. There are trials going on now. One called Titan, as you know, was reported at ESMO last year, very early data. There's other data coming. So we'll get a sense of it, but is it safe to do that, or are some patients going to need combo therapy and miss out up front and have a bad outcome? And or can we define those patients? So it is a really important thing because I think we'd all love to give a little bit of immune monotherapy and have patients do well, right?
Sure.
Forget about TKIs
if we knew, you're bringing up a nice point to segue into the biomarker area. And I think, I'll start with Bob here. Again, coming back to Javelin, Renal 1, they did stratify by PDL1, and they showed that the results were good in PDL1, but also good in the PDL1 low or negative. Do you think that we need to use a PDL1, or it's not prime time for the PDL1, and it's really not in on your list of things to do when you see a patient?
Yeah. So I think for the VEGF IO combinations, I don't really think there's a role for assessing PD-1 and determining treatment of that. With Ipi/Nivo, some of the response rate and the PFS was enriched in this study in people who were PD-L1 positive, but there was a benefit regardless of whether patients were PD-1 positive or not. There's issues with regard to assessing PD-1 in the PD-L1 in the kidney primary versus what's going on with the metastasis, and so I think we need to look at other biomarker tools like RNA sequence and so forth to get a better handle on predicting outcome to IO therapy versus VEGF.
David, you're working on biomarkers. Are we there? Is it prime time? Center stage, or we still have to wait a few more years?
Well, nothing I'm doing is center stage, I would say. It's not easy. I agree with what Bob said, is PD-L1, particularly with the Ipi/Nivo combination, enriches for benefit, but it doesn't help us predict reliably enough that you can say for certain if someone is negative, they're not going to benefit. We see benefit across, PD-L1 staining. We need to do a better job of tissue collection for these studies, and one thing that Bob mentioned was, getting the tumor closer to when you're starting the treatment, preferably from a metastatic lesion. That's the type of thing we did in the Emotion 150 study. We insisted on fresh tissue. We got tissue on 90% of the patients, and were able to analyze it, and we found some interesting things in that study that have held up in other studies, like the Emotion 151 study that Brian and Bob led, and the Javelin study. That signature that predicts benefit for VEGF seems to cross trials from the RNA sequencing. The genes that predict for angiogenesis being active in the tumor seem to predict for benefit with TKIs. Now, that wasn't our goal, but I think if it was, we would be patting ourselves on the back. But we still have a lot more work to do, and I think it is important because some people would really like to identify who are those patients who are going to get the long-term benefit, and be more aggressive in those patients. If you knew a patient had a chance at a complete response, you'd be willing to be very aggressive with their therapy up front, and patients would be as well. So we need to keep at it, I think.
So my issue with the biomarkers for selection of these regimens, or any regimen, I think at this time, sure, I think they inform about the biology. What again, coming back to the Emotion 150 that you led, and you published that in the Nature Medicine, and I think that signature was applied in the Emotion 151 that Brian also presented recently. It's beyond that, information about the biology. It's still really, when it comes to a patient, it's really not cut, and clear that, okay, I'm looking at your signature, and I'm going to select this for you. And then we can come back. Brian, maybe you can take this. And is it still helpful in a way other than just you understand the biology of favorable risk? This is where you think the angiogenesis high signature applies, and maybe that's why they respond to TKIs. And if it's intermediate risk, poor risk, sarcomatoid, they're more inflamed tumors, and that's where you have a high effective T cell, and that's where
I think the Emotion series of studies, 150, which was the randomized phase 2, Dave alluded to, and 151, which was the larger phase 3. The greatest things to come from that studies wasn't the clinical data, it's the correlate data. And so in sum, it's probably almost 1,100 tumors that have had RNA sequencing and DNA and other things. And I think what we found is a few things. One is that those IMDC risk classifications, which are based on clinical features, do reflect underlying biology. Favorable or more angiogenesis high, less T effector or inflammatory high, and intermediate and poor the opposite, as you alluded to. And there are some associations with outcome. Now, those associations I don't think are strong enough, and we're not using it in clinical practice, but I think they taught us a whole lot about the biology of kidney cancer. And there's an even larger effort for Emotion 151, and that data is not released yet. But it's going to be really an amazing story of kidney cancer biology. Not so much to help the practicing clinician in the clinic, but to understand the biologic, and there's this group and this group and this group. And as we move forward and hopefully have new drugs, it will identify new targets. And I'm hopeful before we all hang it up that we get there. That a patient walks in, you're in group 1, you should get treatment X, you're in group 2, you should get treatment Y, et cetera.
Right.
We're not there yet, but I'm hopeful.
All right, 2 things I would add to that. So far, our best marker is sarcomatoid histology. So it's not sexy, it's not expensive. Your pathologist can do it. So if you have sarcomatoid features in your tumor, you're much more likely to respond to a PD-1-based therapy. And some of those patients are out far, 3, 4, 5 years in benefit with our most aggressive tumors. It's a very exciting result. So if you see sarcomatoid histology on a path report, you should be giving PD-1-based therapy, and the Ipi-Nivo data right now is pretty good, but I imagine the data from the other trials will show a similar pattern. The last thing I would say on this subject is really for us to really make progress, I think we need to sort of standardize the way we sample tumors, not just in kidney cancer, but in other cancers. So now on top of pathology, DNA sequencing is becoming more common across tumor types, but we really need to get a better sense of the microenvironment. And to the extent that we do, and for example, if RNA sequencing comes down in cost, it becomes part of a, say, for example, a foundation test, you might be able to say in multiple tumor types, well, this tumor is inflamed, it has a lot of CD8 positive T cells, it's more likely to benefit. But we're several steps away from that, and I don't think in kidney cancer we're on the verge of a companion diagnostic that, to Brian's point, that we can use in clinic. I don't think that's where we're headed.
So it's not like, the story with FGFR3 mutation and bladder cancer,
Correct.
you give them the FGFR3 inhibitor, or like say lung cancer, adenocarcinoma of the lung, where you have EGFR mutation, give them an EGFR.
And I think the reason,
we're not there yet.
One of the reasons is that those are mutations of the cancer cell,
Right.
and the therapies are directed against cancer cells. Our therapies are directed against the stroma, right? Blood vessels and immune cells.
Sure.
So the tumor mutations probably are less likely to affect that. I'm not saying totally unlikely, but they're less likely.
Right.
We're not targeting a
And it's
specific.
most likely it's going to be a profile of multiple, not single one gene, or maybe like you mentioned, a signature of few things that you look at. I want to shift gears now to talk about sequencing. Talking about we talked a lot about the 3 randomized phase 3 trials that are FDA approved for first-line therapy. Now, the patient. It would be great if a patient achieves a CR and, like say with Nivo-Ipi or Pembrolizumab and or Avelumab-Axi, and then doesn't relapse and hopefully has a durable response that will last years. But we know that the majority of patients, unfortunately, do not respond up front, or they respond or they have stable disease for a while and then they have progressive disease. So, Bob, starting with you now. So, if a patient, looking at the 3 regimens, and if you treated a patient off protocol or on protocol with Avelumab-Axi or Pembrolizumab or Nivo-Ipi, and then they progressed, first, when you think about now the next step, the second-line therapy you're going to propose or offer to your patient, do you look at what was the response to that first-line therapy? Did they progress outright, or did they have some stability, or did they have actually a response and then they progressed? And then how would you select your second line depending on what you treated them with in the first line?
Yeah, well, probably the largest factor in choosing the second line therapy is what drug or drugs they received in first line, and also their tolerability. So for me, if and when patients progress or relapse following Ipi-Nivo, it's an easier decision because they haven't had a VEGF targeted therapy. So, I think that there's a number of good choices, and the ones that I usually choose from are axitinib, cabozantinib, or lenvatinib everolimus. Those are kind of the 3. And for the most part in my practice, I usually choose axitinib because I think it's the best tolerated of the 3. And I don't really see that there's a clear difference in efficacy between those 3 options. It's more difficult for me in patients who progress following an IO-TKI because they've kind of already seen both of our mechanisms. So for the most part, those patients have had axitinib in first line, and so I usually give them cabozantinib in the second line. But I think, there's not really adequate data to really lead us in that direction. I think there's a high unmet need there. There's also been, very interesting data recently reported at ESMO using lenvatinib and pembrolizumab with a high response rate in that population. So I think, one of the questions is, is there a role for a continued IO-TKI combination in that population? Or is it better to go with single agents? And that we don't know at this point.
We have to do a randomized trial to really see the contribution of a continued PD-1 or a PD-L1 blockade after the patient already had received the...
Agree, yes.
Brian, what is your approach for choosing a second line?
Yeah, mine's very similar to Bob. So if I would give Ipi-Nivo up front, I tend to give axitinib second. One thing that's new about this era for me is once I've switched away from an immune-containing regimen, I know that I can no longer cure the patient, and then it's just about disease control. And so for me, tolerability plays the most important role, because I agree, I don't think there are proven meaningful efficacy differences among that. We just don't have the trials to show it. So I tend to choose Axi just because it's short half-life and easy to give, very tolerable. I have a lot of experience using it. If I give Pembro Axi up front, which I said I do for the majority of patients, I tend to give Cabo second, cabozantinib. I think it's probably the most active drug they haven't yet gotten, noting that there can be tolerability concerns. And so for a reasonable fraction of patients, I might start at 40 milligrams, a lower dose. And I totally agree that the question of IO after IO is entirely unanswered. The Len-Pembro data that Bob mentioned was very intriguing and seemed very active, but small study, et cetera, so we won't really know. We don't have randomized data, but you can bet that that's, I think, one of the next questions to answer.
David, what about your approach?
My approach is quite similar. If you start on IO therapy, when you get to second line, you're really not in second line. I sort of think of it as VEGF naive in that setting, so VEGF is going to work there. We know that from trials these gentlemen have done with, for example, in the trial that led to axitinib's approval, we know that in an IO-exposed patient, axitinib works great, and probably would work well in this scenario, Cabo the same way. It's harder in the VEGF PD-1 combos to know how to salvage those patients. It's likely that Cabo works when axitinib stops working. I think one of the differences, though, is axitinib, when given with Pembro, is probably given a lot longer, in some patients at least, than it would be if it was just as a single agent on average. So how well does Cabo work in a patient who's been on axitinib for 15 months or 20 months? That's why the answer is we don't know. It might work as well. I would be a little concerned it might work less well. So we need studies in that group, as these gentlemen have said.
So there are some other thought leaders who would advocate, coming back to, why choose a Nivo-Ipi up front is because if the patient does respond, they're, VEGF naive, and so you can really go to your second line with a VEGF or TKI, for example. And whereas if you give them a Pembro Axi, for example, or Avelumab Axi, that they may be compromised in terms of what subsequent. Is that something to be concerned with, this argument, or?
Well, I think that's one rationale, but most people like to focus on giving the best drugs first.
Upfront.
So one approach to that, we're sort of established doublets in the front line as standard of care. We're now experimenting with triplets, and one of those is Nivo, Ipi, Cabo, which is sort of the kitchen sink kind of approach. And that's in a phase 3 trial. So for people who want to give the best drugs first, if that trial were positive, that might advocate for the use of using all 3 active approaches. We'll have to see what the result of that trial is. Toxicity is certainly going to be an issue there. I'm sure other people have other views, but I'm usually not thinking of second line approaches when I'm starting first line.
I want to shift gear here to talk about, we mentioned toxicity, and let's now dive deeply here into the toxicity, because I think this is important for the practicing oncologist who may not be, seeing 20 patients with kidney cancer or 40 patients with kidney cancer, as Bob sees. So how do we, what is your approach to, Bob, managing the immune-related AEs, or just the AEs? Let's say you're giving a patient avelumab and axitinib, or pembrolizumab and axitinib, and they develop diarrhea. We all know that, if they have hypertension, that's the TKI, obviously, and we know to manage that. But if they have diarrhea, so what is your algorithm, your, checklist, what I'm going to do? When are you concerned this is immune-related colitis, or this is VEGF, TKI, diarrhea? So how you manage those?
Well, for one thing, we have very close contact with the nurses and the patients getting these treatments, because I think that's important. And so patients are informed that if they develop diarrhea, they should contact us immediately. So I think nursing follow-up through the office is very important to detect or be aware of problems early. For the most part, in terms of differential, usually axitinib diarrhea gets better quickly if the drug is held. So if a person's having diarrhea and you hold the axitinib even for a couple days, usually the diarrhea, we see pretty marked improvement. It's also generally well controlled with Imodium, and also it's often patients will tell you that it's based on different dietary factors. If they eat this or that, it makes the diarrhea worse. Where colitis is really a different picture, where oftentimes patients aren't having profuse diarrhea. Oftentimes they have 1 or 2 episodes of diarrhea a day, but it's associated with a lot of abdominal cramps. So it's kind of a different picture that we see. And generally, if there's a question in terms of one versus the other, then we usually have the person seen by a gastroenterologist who does a sigmoidoscopy in their office. And it can be distinguished pretty easily based on findings of a sigmoidoscopy.
Brian, your approach?
Yeah, no, I agree. I mean, I think diarrhea being the most common symptom, because each component can cause it. And so it's sort of one of the beauties of Axi is its short half-life, so you kind of know quickly. And also, I think the clinical feel of an inflammatory acute colitis, those patients look sick. You know, it's hard to quantify maybe, but they look sick. Whereas if you just have Axi-induced diarrhea, it's a little more just annoying. You know, they're kind of anorexic, and yeah, if I eat fatty foods, greasy foods, spicy foods, I'll get the diarrhea, and it's, you know, it has just a little different feel. It's never perfectly distinguishable, you know, so if they look sick, then you have to give them steroids, right? If they look toxic, then I don't think you have a choice. Most people don't, and so I think you have time to hold the TKI, the Axi in this case, well, hold both drugs, but if it's Axi, they'll get better in a couple of days, and then you can reintroduce at the same dose or a lower dose.
David?
So I agree with what these gentlemen have said. I think there are some differences, though, between IO tox and IO-VEGF tox that are, I think, important. So the incidence of grade 3-4 toxicity is higher when you combine VEGF and PD-1, but the incidence of stopping treatment for toxicity is higher with PD-1 CTLA-4. So your patient is more likely to be dealing with a chronic issue on VEGF combinations, could be dealing with a more intense problem, you know, early that would require you to hold treatment with Ipi/Nivo. And so patients, particularly with Ipi/Nivo, need to be educated to call. And physicians need to know that they don't have to give a dose. You know, so if the patient is having side effects, you've won. Okay? You don't, if they're mild, you've broken tolerance, the patient's having an immune response. The only question then is, does it shrink the tumor or not? You don't need to give that second or third dose of Ipi if they're already having a mild diarrhea or a mild liver inflammation. Let it get better so that you don't push them over the edge where then you have to rescue them with immune suppression. If you do that, you can avoid a lot of issues, but patients have to call. You know, yeah. If they don't call, the more days they don't call, the more likely they are to be in trouble, be needed to be admitted, have weeks of side effects. So we don't try to scare them, but we try to sort of impress upon them that the earlier our intervention, the more rapidly we can improve side effects.
Of course, you know, all three of you are at academic centers,
right.
And, you know, experienced. We have the nursing staff very well trained to really manage these adverse events and then talk with the patient and the families and make sure that they do report these adverse events quickly, promptly, and you can institute strategies to mitigate and manage these adverse events. So you're talking about, you know, if a patient gets into trouble, let's say they developed colitis, and they have a good response, and you observe them, and they are responding. I want to talk to, ask you the question about the concept of an efficacy endpoint that's near and dear to your heart, the treatment-free survival, TFS, in a simple way for a community oncologist who is really not very tuned to this novel endpoint of efficacy of that. Is this something that you really advocate, and you really think this is an important endpoint for future designs of trials?
Well, I think you asked two questions there. The first one about in a responding patient who's had grade 3 or 4 toxicity, do you restart and when? Typically, if they're responding, I just watch. You had a victory. The only question is how deep is it going to be? How long is it going to last? Oftentimes, that patient who's responding early will stay in response without further therapy. And I usually only reinstitute therapy when the tox is at least grade 1 or gone, or if you see some growth on the scans. So you're not pushed to restart. Because to your point, there are patients, both the good and the bad, of IO-based therapy can continue after you stop the drug. And that's where this treatment-free survival concept comes in, is, as we get better at creating more survival, patients experience survival in different ways. Some of them are survival on treatment, some of them are on subsequent treatment and alive, but then there's this group of patients, which is growing, of patients who are alive and off drug or in treatment-free survival. So we developed the concept of trying to measure that, so we're measuring both the toxicity and the benefit of that treatment-free period. But physicians and patients should know it's possible to create remissions, and we should try to work to make them more common.
So, Bob, just bring back the question about if a patient developed toxicity, but they did not really achieve a CR or a deep partial response, and you can confidently stop therapy and hope that this will lead to a treatment-free survival of 2 years and 3 years, maybe even longer. Do you have concerns of restarting an immune checkpoint inhibitor if they developed toxicity, or once they have toxicity, you feel like that's it? I'm not going to resume that. I mean, let's look at, say, for example, Nivo-AP, and they developed colitis, but they recovered. You treated them with corticosteroids and anti-TNF-alpha, and they recovered. But the patient still has quite a bit of disease. Do you then say, okay, let me wait and see when they progress, then I'll go to something else, or let me go back and maybe drop AP and continue with the PD-1 antibody, and then maybe I'll see, maybe I'll induce a response with monotherapy?
It kind of depends on the severity of the colitis the patient experiences. If it's real colitis, they're hospitalized and required immunosuppressive therapy for quite a while, then I generally don't go back and re-challenge them with immunotherapy. If it's kind of, maybe a little bit responded to a week or so of steroids, then I would consider with monotherapy, Nivo monotherapy. But for the most part, in patients that we've had grade 3 or higher select immune-related adverse events, we haven't re-challenged them with IO therapy, and part of it's because we oftentimes participated in the trial, and so oftentimes we apply the paradigm of the trial to the real-world treatment for the patient, and in most of the trials, the therapy was stopped under those conditions.
Okay, Brian, what's your approach?
Yeah, the same. I mean, the answer is kind of it depends, and I know that's not a great answer, but it's severity of toxicity, frailty of the patient, how much steroids did they require for how long, grade of toxicity, except for maybe the endocrinopathies, and what's their disease doing, and how much burden did they start with, and how worried am I that a little growth in disease is going to impact them, right? So small pulmonary nodules are different than bone lesions, right, in terms of just a bad place to have disease. And so, it's that complex equation in my head where I say, I really want to get them to a point where they're off treatment, right, safely, obviously, without toxicity. And so do I feel like they need more therapy, or not? And so again, it's a vague answer, but it's really just a feel of the clinical severity of toxicity and severity of disease, and sort of making a decision on those characteristics.
So comes down to clinical judgment.
Totally.
As they say in French, sens clinique. So we reviewed the first line therapies. We talked about sequencing, what you give in the second line. We talked about the immune-related adverse events and how we manage those. But there are some other emerging or ongoing. Some of them have completed accrual, phase 3 trials in the first line. Bob, you're involved in many of those. You clearly are, the global PI of the CLEAR study 307, with pembrolizumab plus lenvatinib versus lenvatinib plus everolimus versus sunitinib. The trial has completed accrual, I believe, and we are waiting for the results to read out. And then there is the Checkmate Niner, which is, nivolumab plus cabozantinib versus sunitinib, also completed accrual. We don't have any results. And there is, Cosmic 313 that is now launched and accruing, which is focusing on intermediate risk, poor risk, with nivolumab plus ipilimumab plus placebo, and the experimental arm, the same, nivolumab, ipilimumab plus cabozantinib. How do you look at those three trials, and what are your expectations from these three trials? And now with all the first-line therapies on the market in the clinic, people are using them, and then people are getting, salvage with, if they got a TKI, they get salvage with the immune checkpoint inhibitors. Do you feel like with the design of these three trials and the results are going to meet the endpoints of those primary endpoints that were set a priori for these trials? And what is your, looking at the crystal ball, what do you see?
Well, I think that we've set very high bars now with the results of the Checkmate 214 and the Keynote 426, and with high response rates, long PFS, improved OS. And so I think the expectation is that these trials coming kind of need to meet those bars as well if they're going to be successfully or trump those studies. So certainly the hope is that they will meet the bars and reach both primary endpoints in progression-free survival and overall survival. That's the hope, and that's what we're hoping to see with those trials. Whether they will reach the OS benefit because of efficacy or because the things have changed and patients are getting immunotherapy in second or third line and their survival is being moved longer and longer and longer, whether they're going to be impacted upon by kind of real life treatment now around the world with IO therapy and salvage, and that's going to offset some of the efficacy endpoints. I mean, we'll have to see.
Brian, question to you. You just give us your prediction, not who is going to win the election, but prediction of
how these trials are going to
how
turn
these
out.
trials are
So
going
I
to turn
think
out.
the two VEGF IO trials, Len-Pembro and Cabo-Nivo, I think will have response and PFS results similar to Keynote and Javelin. There's no reason to believe that they're going to be much better or worse, in my opinion. And I have no direct experience, and I'm not involved with those particular trials. The OS signal could be diluted by, as Bob said, now the wider availability of subsequent therapy than there was when, say, Keynote was enrolled or Javelin. I still think they'll meet their survival signals, but I think it's a little more of a question mark. How they will impact the field if they come in exactly the same and how they'll be used, I think is a different question. I'm not sure, because actually Pembro will have been around for a couple years by then. Cabo-Ipi-Nivo is very different. Right now we're talking about triplets. I do think that study will be positive as well. I think the question will be tolerability. Ipi-Nivo, as David said, up front has toxicity to get over, and I think it's something that prevents some practitioners from using it, is sort of the fear of Ipi, as I like to call it. So if you throw a toxic TKI in there, my concern is that, real and or perceived, that it might be very difficult. I do think that kind of triplet approach is where we're headed. I'm just not sure about that particular regimen.
So David?
No, I agree. I think the only one of these trials that we've talked about that could change the paradigm that we're in right now is the triplet. Right now, we're advocating for PD-1-based combination therapy for almost every patient except those with active autoimmune disease. And then the only question is VEGF or CTLA-4 is the combining partner. These follow-on studies are going to be likely very similar in their results, and we're going to have a muddled mess of 5 or 6 trials that we're trying to compare, but they're probably going to say very similar things.
So if none of these trials that haven't read out yet meets the OS endpoint, and they have response rate in the 50, 60, 65%, right. PFS in the ballpark of the other trials, like say the Pembro-Axi, Avelumab-Axi, and they don't get OS, do you think they're going to have a seat at the table? Will they really have?
Yeah, I would doubt it, particularly since, as Brian has said a couple of times, Axi is easier to give as the clinician than Len-Pem or Cabo, which have much longer half-lives. They take longer to go away. I think the one exception to that prediction would be if you see a signal of higher deep response rates, higher CR rates in those combinations. If for some reason that adding a dirtier drug like Cabo that gets not just VEGF but MET and AXL, if that enhances the immune response to the tumor and that translates into more CRs, so let's say we saw a CR rate on that trial of 15%, that might motivate people. You could argue it shouldn't, but that might motivate people to try a combination
Even if
that doesn't
no
have
OS
correct.
benefit, if the
Correct.
CR rate is above 10%
Correct.
or above 15%, and the objective response rate like in the 70, 80%, like with pembrolizumab, for example, pembrolizumab, lenvatinib, that even if there is no OS signal there, that might motivate. Obviously, it comes down to also tolerability, as Brian said. You know, even if you have a high ORR and a longer PFS, if there is no OS and the toxicity is significant, then I think that is going to obviously influence people. Do you believe that there will be at the end, when all the dice is cast, at the end there's going to be IO standing, Nivo-Ipi, and then 5-6 contenders of IO TKI, and how do you see that? Is this your black and white?
Meaning, are you asking me whether Ipi-Nivo will win out in the end?
No, whether there will be the people who will
Yes.
choose Nivo-Ipi for a good number of patients, let's say intermediate risk, poor risk, and then the PD-1, PD-L1 plus a TKI, whether it's axitinib, cabozantinib, lenvatinib, that's going to be the other camp. And then, do you see that this will be
Sure.
the competition will be in the IO TKI space camp? There will be many contenders there, but then there's the Nivo-Ipi.
Well, given the comfort of combining VEGF and PD-1, two approaches that most oncologists, particularly in the community, have used for many years, I think that's likely to be the most applied combination when you add up all of the different regimens comparing to Ipi-Nivo. But for those clinicians who are comfortable managing toxicity, I think there'll always be a benefit to Ipi-Nivo, particularly as we get longer follow-up, as we start seeing those flattenings of particularly the progression-free survival curve on some of those trials and quality of life. There'll be advocates on both sides, but most patients will probably end up getting VEGF PD-1, particularly in the community.
Bob, a question that's on the mind of a lot of people, and I heard you, at a different meeting, talk about, the question was asked, how long do you treat patients with PD-1? And of course, as we all know, the trials, the ones that were finished and the ones that are ongoing, put a 2-year limit on the duration of a PD-1 antibody. So if the patient hasn't had toxicity, do you, because I heard you say that you will continue beyond the 2 years if they haven't had any toxicity, and of course they're getting their drug covered. Is that your approach? And give us the rationale for that.
So for the trials that we did, the Checkmate 214 doesn't have an end to the Nivo.
Right.
So even the patients we put on in 2014, some of them are still getting nivolumab. Same thing with the Javelin 101. There's not a 2-year, it's just continuous. So for the most part, most of the patients I treat have been on trials, and if the trial says keep going, we keep going while the data is picked. For the most part, the one that has a 2-year limit are the Pembo trials. So translating that into real world treatment again, for the most part, I usually follow the paradigm of the trial that we use that was successful. So most of my patients, I just continue them on the immunotherapy, and once they're on it for a long time for nivolumab, it's a once every 4-week infusion. I think it's very reasonable if a person has a complete response and they've completed 2 years of treatment to stop the therapy after that. I think that becomes a discussion between the doctor and the patient. But for the most part, the patients who have durable partial responses, unless we have some sort of pathologic confirmation that they're in a CR, I generally continue them on treatment.
And the reason is because you do not know if, what's the optimal duration, whether 2 years is enough or whether we need a longer duration.
Agreed.
Obviously, the implications there are financial and, possibility of long-term complications that are not, really predicted right now. Brian, is that your approach, 2 years?
So
or
no,
go
it's
beyond,
not.
continue?
I mean, we don't really have any data about stopping therapy and what happens. In 426, it was stopped at 35 doses or 2 years, but we don't yet have the data because those patients really just stopped over the last year. I tend to have, as we get to that 6-9 month mark, if they're having a nice response, they've clearly generated an anti-tumor immune response, which should persist. So then I'll have a discussion with the patient. Certainly, if there's any toxicity, that's an easier choice. If not, then it's a discussion. I have many, many people where we've stopped for one reason or another who are doing fine off therapy. And so how long you need to continue, I think, is very much an unanswered question. And there are trials going on now to address it. But I tend to at least have a conversation with the patient. If they want to continue, I'm not going to stop it on them. But I try to talk them more into stopping than continuing, I would say.
David?
I would agree, although my stopping time is usually later than Dr. Rinnie's. Usually if it's 18 months, 2 years, where we've stopped in other trials and seen benefit persist, I'm more comfortable stopping then. But it's a conversation with the patient. Now, some patients, particularly if they're just on PD-1 alone, they're not usually developing new side effects, not lack of cumulative side effects, which is one of the benefits of PD-1 alone. So the patients often don't want to stop. So you have to go back and forth and educate the patient on the pluses and minuses.
What is now, to wrap up, and I think this is a great discussion. I hope the listeners, learners will benefit from this discussion from experts like yourselves. What is the most exciting discovery, agent, therapy that you look over the horizon and you see this in RCC? David, you're involved in many.
The most exciting discovery is the VHL-HIF story, which recently got the Nobel Prize in Medicine, and trying to understand that biology. It's now being translated into kidney cancer targeted therapy with HIF-2 inhibitors that are now entering phase 3 trials. That's probably the most interesting new target for us in kidney cancer.
Brian?
Yeah, I agree. I think in terms of the most clinically advanced, about to take the next step, it's HIF inhibition. Then I think everything else is sort of down there, and other immunomodulators, et cetera. But I'm not aware of one that I think has really sort of jumped to the forefront.
Bob, how are we going to cure patients with kidney cancer? I mean, is it a triplet, a quadruple? Is it is it going to continue to be an IO based plus an exciting new target like HIF2 alpha, combining, or dual TKI continue to have a role?
I think it could be any of those. I think it could be new, novel drug, how to use these agents, picking out the right population. In addition to the HIF inhibitor, I mean, I'd love to see studies move forward with CAR T cells and RCC. I think that's another exciting area for investigation.
On that note, I would like to thank my panelists for participating in this activity, and hope that the listeners, learners will complete the post-test and evaluation to receive credit. Thank you for your attention.